Welcome to the PERC rule, also known as the Pulmonary Embolism Rule-Out Criteria. This is a clinical decision-making tool that, when used right, is incredibly powerful. But it's also something that I've seen misused quite a bit. So today we're going to go through what are PEs, how we diagnosed them, how this rule was actually derived, the data behind it, and how to properly use it. So to start, what is a pulmonary embolism? Well, it's a blood clot in the lungs. Traditionally, these all start with a DVT, or a deep vein thrombosis, clot in some of the veins, oftentimes the legs. People who are high risk of these are people who have a clotting disorder, recent surgery, people who are not moving, or have any damage to the vessels of their veins. Sometimes, if these DVTs are untreated, they will kind of propagate up the vessels, go into the heart, and then get lodged somewhere in the vasculature of the pulmonary arteries. Once you get stuck in that lung, effectively what you're going to do is you're going to block off circulation to a certain portion of the lung tissue, and that lung tissue is going to start to infarct or die off. This is going to cause people pain, right? This is going to cause a feeling of shortness of breath. Over time, as this clot gets bigger, a lot of this blood is going to backflow into the heart, and so you start to have heart strain. Their oxygen levels are going to go down, and sometimes in rare cases, as these clots get bigger and bigger and bigger, you're going to block off all circulation to the lungs and can even cause death. So it's incredibly important that we diagnose these correctly, especially in the ED setting. But the diagnosis tends to be a little tricky, right? A lot of times PEs are not as obvious, especially small, subtle ones. And so what are the tools we can use to diagnosis? The ultimate one is going to be a CT scan, or a CT scan with a pulmonary embolism angiography, right? Blasting the vessels with contrast, so we see if there is a piece of vessel that is not filling up with contrast. Now, the major downside to this is, for at least the patients, it's a lot of radiation, right? We're scanning basically from top of the neck all the way down to below the diaphragm. Ton of radiation. It's also a decent amount of cost, and from an ED perspective, it's also a lot of time, right? As in, if I have someone that I know does not have a PE and I can avoid it, I can save them radiation, save them cost, and save them time in the ED. There has been other studies that looked at this and said, okay, if someone is truly low risk, then let's use a blood test. Let's use a D-dimer as a way to evaluate these folks for low risk PEs. If it is truly negative, then you'll say, hey, probably no PE. And if that D-dimer is positive, then, oh, you might have a PE. Let's confirm with that CT. Now, the issue is the D-dimer has a lot of false positives. That is, a lot of people have, for another reason, a positive D-dimer that is not from a DVT or a PE. And so you'll see a lot of people with positive D-dimers that ultimately still have no PE. And so this D-dimer also itself requires a blood test. And so the question is, for people who are truly, truly, truly low risk PE, is there something to help the clinician say, hey, they're so low risk that I don't even need the D-dimer to start with. I don't want to get in this game where it's positive and I have to follow up with a CT. Can I say definitively that there's no PE? And the first part is definitively no. Right? No test in medicine is perfect. But the concept that a lot of the authors of this test go after is a test threshold, right? How accurate you have to be is accurate enough or low risk enough that there is more harm in testing someone than there is in not, right? And so the reason behind that is even CAT scans, CTPEs, are not perfect. sometimes they even have false positives, right? Someone we find a PE on their scan even when they truly don't have one. Also, the cost, the radiation, everything. Ultimately, we decided a test threshold is somewhere between 1 to 2%. Okay, that 1 to 2% of people without a PE will be harmed by just going through the workup of a PE. And so if you can get the risk of a PE, if you can risk stratify a patient to say this patient has under, let's say, a 1 to 2% risk, then at that point, the risk is below the test threshold, and we do not need to do any additional workup, right? And so the goal of this PERC rule is to try to get people below a 1 to 2% risk, right? You are so low risk that doing additional testing, such as blood work, such as CAT scan, is not needed. And so let's talk now a little bit about the data of how they got this. So the study was done by the Klein group back in 2004 is when it was published. And to start, they looked at about 3,000 ED patients with a concern for a PE. All right. This is a multi-centered study. And they looked at effectively 21 variables. All right. So 21 things that were historically associated with PE. This was a sudden onset of pain, pleuritic pain, low O2, high clot risk factors. And they, of all these patients who had a concern for PE, they looked at what had the truly highest risk or highest association with a PE. And in that case, that was these eight criteria were the most associated with PEs, all right? So that's age over the age of 50, a heart rate over 100, O2 less than 95%, hemoptysis or coughing up blood, hormonal use, any recent surgery or trauma, a prior history of either PE or a DVT, or any signs of unilateral leg edema on exam. Okay, these were the 8 factors that were highly predictable for having a PE. So the idea was if you had none of these, you probably were really, really low risk of having a PE to start with. All right, so after they derived this PERC criteria, they wanted to initially test it out on 2 groups. So the first group was a group of ED patients that the clinician thought were low risk for PE, right? This is the group that historically would have gotten a D-dimer testing, right? These are people who said, you probably don't have a PE, but because I'm somewhat thinking about it, let's just go through a check. So all these patients were ultimately followed up to 90 days. So if they had a PE, obviously you had a PE, it was treated. But even if you did not have a PE, they wanted to make sure that even after the ED visit, you weren't going back to another hospital or someone else did not diagnose you with another PE. So ultimately in this group that were considered low risk, actually 8% of them had PEs. That's a pretty high rate. And all of this, they then took the PERC rule, right? So they said, let's stratify all these 1,000 patients and look at people who were PERC negative, as in you had none of these features here, right? So that new population ultimately had a rate of PEs of 1.4%, right? So we went down from 8% in the general population that were considered low risk clinically, and when you use the PERC rule, you brought it down to 1.4%. That's pretty good. Again, our goal is to get below 1 to 2%, right? So in this small group, yeah, we did it. The second, they also tested this another time in a different group at a different hospital that they considered very low risk. These are people that probably had another diagnosis for their shortness of breath. These are people that the clinician almost didn't even want to get a D-dimer in. All right. They too, some of them got ED evaluations, but also were followed 90 days after ED discharge to make sure, did we miss any PEs? And of that group, they had 2% of them had PEs, right? This is truly low risk. They also then used the PERC rule on these patients. And when you look at that subset of patients, you had 0 PEs, right? So the PERC rule was able to exclude all PEs in a very low-risk population for clinical suspicion of PEs. That's pretty good. The one drawback from that initial 2004 study was that these are kind of small populations. The 1,400 is not bad, but in the very low risk, you only looked at like 300 people. And so the main limitation at the time was the validation aspect of it. So 4 years later, this group then published a second study where they validated this tool in a much bigger population. In this case, they had 8,000 ED patients, multi-centered again, who were coming in for evaluation of PE, where they had dyspnea, chest pain. Some of these people were diagnosed in the ED with PEs, and those who were not were followed up 45 days. So they were looking at outpatient, looking at people going to other hospitals, looking at even autopsy reports to see, of all these people, who truly had a PE. And in this case, 6% of this overall population were diagnosed with a PE within 45 days, right? So decently high amount of PEs. So then they divided this subset for look at two things: people who were considered low risk by the clinician and PERC negative. All right. So how many of these people, both the clinician thought there wasn't a PE and they used the PERC rule, right? Those 8 criteria. So out of here, now you have 1,600 patients that fulfill that criteria. And in this population, you had a 1% risk of PE, right? So we brought an overall population that had 6% PEs down to 1%. And again, this is not perfect. This is not 0%. But the idea is that if we can get below or at 1%, this is below the test threshold where it is not even warranted for additional testing. So now let's take a look at how we use this. This is the PERC rule on MD-Calc, which is how I use it most often. Effectively, you could also just write down the list or memorize it, whatever you want. But effectively, it is just a checkbox of yes and no questions, right? Is someone's age greater than 50? Yes, no. Is their heart rate greater than 100? Yes, no. If you answer no to all of these, then effectively, just like we said in the data, your risk of a PE is less than 2%, and thus we should not do any other provocative testing. Now, if you say yes to any of these, and it doesn't really matter which one, if someone's age 51, you can't use the rule. If someone has hemoptysis, you can't use the rule. It doesn't matter which one. As long as you do not satisfy all of the criteria, the rule becomes invalid. You cannot use it. And next, I want to talk about the major limitation of the study. So one, like I said, this is a high sensitivity, low specificity study, right? So yes, we will probably catch 99% of all the PEs in the study, but just because you are PERC positive does not mean you have a PE, right? It's only useful if it is a negative test. The other one is that it absolutely requires clinical judgment. All right, we cannot use this alone as a checkbox. It is not designed to be a checkbox. even in the deviation study, it is not just the PERC rule alone, but it requires a clinical low-risk assessment of a PE to then be applied. And so for very early trainees, medical students, you may not have that clinical judgment yet. You have not seen enough true PEs or enough false negative PEs or false positive PEs, people that sound like they have a PE but don't actually have a PE. And so until you see enough PEs, it may be very, very hard to say who clinically has a PE and who doesn't. And again, that is the major thing, right? This is not a checkbox tool, right? This checkbox cannot replace clinical judgment, clinical evaluation, okay? And so I just want to go through a quick case of when the rule should be used and should not be used, all right? So case 1, we have a 35-year-old female with a history of asthma. They're coming into the ED with shortness of breath for 1 day. When you examine them, they are wheezing. They're audibly wheezing on exam. And let's say they tell you, this sounds like the last time I had really bad asthma. And the rest of the criteria is negative, right? They're PERC negative, as in their heart rate's not over 100, their SAT's not less than 95, they don't have leg swelling, there's no hemoptysis, there's no surgery, they've never had a P or DVT before, and they don't take any hormonal birth control. All right, they're PERC negative. And so, on my presentation or in my thinking, I might say, hey, this is someone who's coming in with shortness of breath. It sounds like their asthma. When I look at them, they look like someone who's having an asthma attack. I will treat them for asthma. But if I were to keep a full differential of all the causes of shortness of breath, PE is a cause of shortness of breath, but they are so low risk clinically, I don't think they're having a PE. I think this is just asthma. And to, make myself either feel more confident, make myself sound smarter, or, to justify it in some way, I say, yes, I agree they're low risk, and I'm going to use a data set that says they are so low risk on top of my judgment that they don't need any additional testing. I'm not going to get a D-dimer on this patient. I think this is just asthma. All right, that is how you apply the PERC rule. Now, let's look at a different case. Case number 2. So this is a 26-year-old male with a history of factor V Leiden. Right? Factor V Leiden is a genetic disorder that makes you very high prone to both DVTs and PEs. Now, this patient's coming in with shortness of breath and pleuritic chest pain for a day. You do your exam and their lungs are clear. And you ask them, the PERC questions. No, they're not over age of 50. Heart rate's fine. O2 fine. O2 sat's fine. And because they're 26, they have no history of a PE or DVT. And you look on their exam and you don't see, a giant leg. Fine. This is someone who, clinically, they're high risk for clotting. They're coming in with the classic signs of a PE, that pleuritic chest pain. This is someone who needs an evaluation for PE. And some clinicians might even call this person even high risk for PE, right? They might even skip the dimer and go straight to a CAT scan. Now, technically, if this person's heart rate was under 100 and their SAT was over 95, technically, this person, by PERC criteria, would be negative. But this is not the patient you can use PERC on, right? Because just because I have a clinical suspicion, I think this patient might have a PE, I immediately cannot use this rule anymore, okay? And so I want to make sure you understand the pathway of the PERC rule, okay, and how we use it in clinical assessments. So someone comes in, so you have a patient come in, and let's say they have, chest pain, maybe a little dyspnea. All right, this patient gets evaluated by me, by my clinical judgment. All right, and I might say this person is extremely, extremely low risk, right? I think they have absolutely no way this person's having a PE, right? I'm going to get from there, I'm going to get a PERC test. If they are PERC negative, then I'm effectively done. All right. I can definitely say this person I think is low risk PE. I have a data set that says because they are so low risk, I'm not going to do any additional testing. Okay. Now, they might be PERC positive. It does not mean I definitively have to use another study. It just means I can't use this rule. I can't say, hey, I'm going to use the Klein 2008 data set to justify why I'm not doing additional testing. But if I truly think they are low risk and I don't want to get involved with the D-dimer, I might say they're done. Or I might say, hey, I'm not so sure anymore. I think clinically they are low risk. But historically, even in the prior study, people who clinicians thought were low risk still had, greater than 1% of PE. So maybe I'll dimer this person. Maybe, right? Or nothing. Okay? Now, if someone comes in and they have, let's say, a low/moderate risk, then I think I ought to go for the dimer. And again, if they are high risk, then I'm going for the CT. And if the dimer is negative, then I'm also done. And the dimer is positive, then I'm going to go to CT. So this is kind of my general approach to people evaluating for PEs, right? Low risk, use the PERC rule. If you don't think that they're low risk, if you think they're a low moderate risk, do not use the PERC rule, right? That is not who it was intended for. That is not how it's going to be used. All right. Hopefully you thought this was helpful. I will leave a link to these notes if you want to print them out or write additional notes on them. And let me know if you have any questions in the comments. Thanks.